Okay, so when making the clinical decision to place a central line catheter, I'm going to go over the indications. Indications including the need for volume resuscitation, anticipating the need for vasoactive infusions for hemodynamic stability, and needing to transduce it for maybe CVP monitoring. So I'm going to go out and meet the patient, go over risks and benefits of the procedure, and obtain consent. And while I'm out here with this patient, I'm going to assess the sites for which, if I'm going to go right or left. So the right's preferred, it's a more direct access to the atrium. The left is indirect, and there's anatomical structures on the left, such as the thoracic duct. So I'm also going to assess the right side for any signs of infection, redness, swelling, warmth, which there are none on his right side. So we're gonna do the right side today. So we're gonna come back to the OR. I'm gonna make sure I have all my monitors, my resuscitation equipment, and I'm going to do the ultrasound technique. So I'm gonna make sure that's in here, set up, and ready to go. And I think we're good to go for that. I'm gonna go ahead and induce the patient, and then get him in a position conducive for central line placement. I'm gonna do a slight Trendelenburg, head turned away from the insertion site to optimize access, and then maybe take his pillow out too if I need to. That's the slight Trendelenburg will allow for venous engorgement, easier access for me as well. Once I've got him in position, I'm going to identify my external landmarks. Got the sternal head of the sternocleidomastoid muscle, the clavicular head, my clavicle. I'm going to be aiming for the ipsilateral nipple, cricoid cartilage here as well. And those are my landmarks, and they're easily identifiable. Now I'm going to open up my kit. And prep the site. I'm going to go in a triangle from the sternum up to the sternocleidomastoid muscle down to the ipsilateral nipple. Go ahead and give that a good scrub and let that sit and air dry. I'm going to go and continue opening up my kit so it's ready to go. I'm going to obtain any necessary supplies that I might need as well that are not in the kit, and these include a Tegaderm, which I've gotten, as well as a BioPatch for when the time comes to dress it. Okay, all this is good. Now I'm going to don my sterile gown and my sterile gloves. I'm going to open up my gloves first, make sure those are ready to go for when I'm gowned. I'm going to have my coworker come over and fasten my gown for me. Cuff to cuff, thumb to thumb. Go ahead and drape the patient. Okay. Go ahead and identify my landmarks again. Again, I've got the sternal head of my sternocleidomastoid, my clavicular head, and my clavicle down here that I can palpate. So I know I'm in the correct position. Now I'm going to go ahead and get my kit ready to go. Got some gauze. Make sure everything's uncapped. Got my scalpel, my dilator, my guide wire, my catheter, make sure that the tip is intact, and it is. Make sure that the distal port is unclamped, the other two are clamped. All right, I'm gonna have a coworker drop my ultrasound transducer sleeve into my sterile field. Okay. And my rubber band, thank you. All right, I'm gonna have them hand me the transducer, maintaining sterile technique. Thank you. My rubber band. Okay. Now I'm going to identify my internal landmarks via ultrasound. Use some sterile gel, apply it to the patient's skin. All right. So I'm looking at, all right, so I see the carotid artery pulsating. I know that the IJ is just lateral to that. Let me check the orientation of my probe. All right, now I have a correct orientation. All right, there we go. Carotid's pulsating. I know my IJ is just lateral to that. It's compressible, it's not pulsating. All right, I'm gonna get my IJ in the middle of my screen. And get a stable hold on the transducer. I have a good view. I'm gonna go ahead, insert my needle, bevel up, 45-degree angle, aiming for the ipsilateral nipple. Aspirating as I insert, watching for the needle insertion on the ultrasound screen. All right, and I have blood return, dark red blood, and I see it on the screen. Go ahead and drop my angle, aspirate again. I'm still in place. Advance my catheter without advancing the needle. So I have dark red blood, it's not pulsating, so I know I'm venous, not arterial. I'm gonna go ahead and, utilizing the Seldinger technique, advance my guide wire. To approximately 12 to 15 centimeters. Okay. All right, I'm gonna hold that in place and withdraw my catheter. With the guide wire in place, I'm gonna check it via ultrasound. See if I can visualize it in the vein. Do an in-plane view. I can see it right there. That's another way of confirming that I am in the vein. All right, I'm gonna perform a skin knit away from the guide wire. I'm going to thread my dilator. Feeling for the pop of the platysma. And thread my catheter. Wait, I'm going to be looking for it to be exiting the distal port of the catheter. I'll be doing somewhat of a push-pull. All right, I have it outside the distal port, so I'm going to grab this and advance. All right. I'm going to withdraw the guide wire the rest of the way. I'm going to go ahead and suture, place my bio patch, place my Tegaderm, get that dressed, and then hook it up to my transducer, assess the waveform for accuracy of morphology as my other confirmation of placement, and start the procedure.